Hello and welcome to Team Jedi's final presentation on our healthcare predictive modeling. Today we're going to take you through a little bit of the background about why we did this project, some of what we discovered, the dashboards we've created, and also a tool review, and a little bit about the future, what we think it looks like. So we're going to start off today by having Ernest start off by introducing the business case for why we did what we did. Ernest?
Thank you. This is a discussion of the business case for XYZ Hospital readmission. With the introduction of the Affordable Care Act comes the introduction of penalties for patients that have been readmitted within 30 days. With Medicare and Medicaid being the largest payer with 57% of the market, it is important for organizations to act responsibly to avoid these penalties. In order to obtain the best sample possible to resolve this concern, our organization has chosen to use a data set that is heavily skewed for those 65 years and older, as this is the biggest population of Medicare and Medicaid patients. Okay, next slide. Okay, there we go. So a little information about readmission data at XYZ Hospital System. It has 25,000 discharges per year with an average payment of $10,700. Patients readmitted within 30 days may incur a penalty of up to 3% based upon a national average. Based upon revenues generated, XYZ Hospital is at a risk for $1.6 million due to readmissions. Next slide. So next, we will discuss the financial impact of improved bed management and how it impacts readmission. XYZ Hospital System has 1,000 beds in 5 hospitals. This allows the organization a profit of $80,500 per bed per year, with a total revenue of $80.5 million. Utilization improvements of just 2% would result in a savings of $1.6 million. Next slide. So why a study? Why a diabetes pilot study? Diabetes hospitalizations have doubled from 1997 to 2009. Diabetes patients have a higher risk of readmission as the primary diagnosis and also 15% as a secondary diagnosis. The data analysis for this pilot will help determine where the biggest opportunities for reducing readmission can occur and provide an opportunity to predict patients at risk for readmission. This will assist the organization in mitigating the risk of future fines and penalties and will also serve to control cost and improve quality of medicine at XYZ Healthcare. Okay, so next, I believe we have the project goals.
Thanks, Ernest. I can take those. So our project goals were to predict whether or not a patient will be readmitted. Our primary objective here was just to predict readmission regardless of the time frame, so whether it was within the first 30 days or greater than 30 days following discharge. The next goal would be if we were able to predict readmission, we wanted to go ahead and then try to narrow down the time frame, with particular interest paid to the less than 30 days for the reason that Ernest stated, which is the Medicare penalties. We also, for goal number 3, wanted to predict length of stay. Since that was predicting an amount of days, we opted to use linear regression for that prediction. And we were also looking to, with goal number 4, develop some patient profiles. Next slide, please. Okay, so I'm going to go ahead and cover data analysis and modeling. Next slide. Thanks. Okay, so just a few points regarding our data set. Whenever you're looking for a data set, you want to make sure that there's a couple of things that are criteria that are met, and one of those is reliability. We definitely feel our data set has met that criteria since it came from the Virginia Commonwealth University and was part of a grant from the NIH. Another important thing you want to look at are the number of observations, so the volume of the data. You want to ensure that you have enough volume so that you can trust the modeling and the outcomes. We definitely feel our data set met that criteria with greater than 100,000 observations. So the data was somewhat granular in that we had data at the specific patient encounter level. We had data like gender, race, age, but we also had data around medication and labs. So we felt very confident moving forward with this data set and using this for our study. Next slide, please. So data transformation and enrichment. One of our challenges was that a very large portion of our data was comprised of categorical variables. We went ahead and transformed those into dummy variables, and that gave us sort of the maximum flexibility with our modeling. And then diagnosis code. I'm not going to get into like every field in the data set, that sort of thing, but diagnosis code was one that stood out to us pretty early on in the process. We could tell that it was going to be predictive. So our challenge was that there were actually a lot of unique values for the diagnosis code, 698. And we knew that would complicate our modeling, and so for that reason, we decided to roll the diagnosis code, the ICD-9 codes, up to diagnosis class. So that allowed us to retain a level of detail that made our models easy to interpret and gave us good descriptive data, things like we could still tell if the patient had heart disease, COPD, or some other disease process. But it allowed us to reduce that number down to 90 unique values, which was a lot more manageable for our modeling efforts. Next slide. So I just want to touch on high value variables, and I'm not going to spend a ton of time here, but throughout the analysis, we were looking for variables that would provide us the greatest predictive value. We used several methods to extract the variables, and one of those methods is shown below. This is a random forest variable importance plot, and the most important variables are shown at the top. Just showing this slide really to point out that throughout our analysis, we're constantly looking for those high value variables. And just keep those in mind as we move forward. And when I'm doing the closing for modeling, I will touch on a couple of those high value variables and some projects that we recommend to those. Next slide, please. Okay, so just to tie back to our goals, for goal number 1, we wanted to predict readmission without regard to time frame, so regardless of whether it fell in that first 30 days post-discharge or greater than 30 days. We decided to take 2 approaches here. One was to predict readmission using variables available to us at the time of admission or shortly thereafter. For this first approach, logistic regression was used, and that was our sole modeling method used for this particular approach. We did a lot of different models here as far as the number of models. The top 3 are shown there in the table. One note regarding the measure that we used to decide the champion model in this case, it's ROC, and just some perspective on that number, 50%, so 0.50 wouldn't be the same as like a random guess. And so, for example, if you were to flip a coin, you could get heads, you could get tails. You have a 50% shot either way. So just to get perspective, you can see that our model performed well above that random guessing, 50%. We thought the model performed okay, but it wasn't so great, so we decided to move forward with approach number 2. Next slide, please. So for approach number 2, we're still predicting readmission, yes or no, so regardless of the time frame. But this time we decided to tackle it using variables that were available throughout the patient's stay up to discharge. So we used different modeling methods here as well. So we used logistic regression. We added those additional variables. We took a look and saw how our model performed. But then we also tried using random forest and support vector machines. Again, I don't want to get too deep into the minutiae here, but just to say that we did see some improvement in our model. But bottom line, we didn't feel like the model saw enough improvement to choose it over that first model using approach 1. And really the value for the first model was that we could predict readmission earlier in the stay, which gave us a greater opportunity for intervention. Next slide, please. Okay, so for goal number 2, was predicting readmission within a time frame. Again, we wanted to focus on that first 30 days post-discharge. And the main driver for that was the Medicare penalties. So what we did with goal number 2 is we used multiple models again. And then based on the model statistics shown, you can see that it was our logistic regression model that performed best overall using that ROC measure and accuracy. So this is out of all of our modeling efforts thus far, this is our champion model and the one that we'll recommend moving forward with. Next slide, please. All right, so for the third goal, that was the goal to predict length of stay. We tried several different models using linear regression. However, the variables just weren't there to give us the kind of outcome that we were looking for. So with predicting length of stay, obviously the earlier in the process that you're able to do that, the better off. So we feel that even though we weren't able to move forward with recommending this as our champion model at this point in time for its purpose there, we do recommend bringing it into the XYZ environment for further investigation. Next slide. All right, so our fourth and final goal was around clusters, building patient clusters in order to uncover any sort of natural clusters in the data. Of particular interest was obviously whether or not our patients would fall naturally into these different readmission timeframes, so less than 30 days post-discharge, greater than 30 days, or not being readmitted. So all in all, we felt that the model didn't perform to the level needed in order to be selected for that purpose. However, throughout our analysis process, we did uncover a frequent flyer group. And we have a table there that kind of shows you the difference between our frequent flyers, people who are admitted often, as opposed to people admitted less than having 4 admissions. So you can kind of see that they have a greater number of diagnoses. They have more inpatient stays on average, and the time that we spend in the hospital is actually also greater than patients with less admissions. So we feel that this is another model where we could bring that into the XYZ environment, run the model against our data, uncover our frequent flyers, and then perhaps use that to our advantage right away. One immediate step would be to alert our case management team of our frequent flyers and allow them to intervene with hopes of eliminating future readmissions. Next slide. So just to wrap up for modeling, we recommend moving forward with a logistic regression model that we use to predict the readmission in less than 30 days. We also recommend moving forward with the length of stay model. We feel that by bringing that into our environment and enhancing it with our variables, the variables that we can collect at the time of admission, we could improve that model. And then just to touch on, again, those high-value variables, things that were highly predictive, here are a couple projects that we recommend moving forward with. We recommend that you pull together a team to look at patients discharged to rehabilitation facilities, as our analysis indicates that this group is at an increased risk of readmission. We also recommend that a study be performed to look at patients admitted under the specialties of infectious disease and nephrology. So without further ado, I will turn it over to Allison, who's going to do some demonstration of the models, which is definitely the good stuff. All right, Allison, all yours.
Thanks, Sharon. So with all of this modeling output, what's very important is to actually put this in the hands of the end user, which would be the healthcare team, such as the doctors and nurses. So we developed a suite of dashboards intended for the doctors and nurses to leverage that would basically allow them to utilize all this modeling output to take care of their patients even better. So we have 3 dashboards as part of this suite. The first would be to help the doctor predict the probability of readmission based on the different factors of the current patient they're treating. The second would be to compare the average patient. So they could select maybe a couple of features that would be related to the patient and then see how they compare to everyone else. And then finally, they could use the existing patient ID to see if they've been with us before and what their history statistics were previously. I'll jump into that. Okay, so this is the first dashboard that would help to predict the probability of readmission. So here, this percentage up here is the percent likelihood that they would be readmitted in less than 30 days. And then here we have several different inputs that the doctor or nurse could choose to help the model determine how likely it would be that they'll be readmitted. So I'll pick a scenario of perhaps my patient is Caucasian in the age of 70 to 80. Their admission source, perhaps they came in through an emergency room. And once I made that selection, you'll notice that the percent probability actually increased. And that was one of the ones that Sharon had mentioned, that we had found that emergency room admissions had a higher impact to readmissions. She also mentioned nephrology was a high indicator of increasing readmission. So we have that selected, which is contributing to the 69%. But if I maybe pick something else, like podiatry, that actually increased even further. Diabetic patients often have issues with podiatry, so that also increased that as well. Here they are taking diabetes medication. They are a diabetes patient. And then if I toggle around with these a little bit, maybe let's reduce the number of their emergency room visits. That actually decreased their rate. So that makes it look like they're a little bit less of a frequent flyer. Finally, we could perhaps change their diagnosis from their visits. So perhaps they had an injury to the blood vessels, and it doesn't look like that had an impact on their likelihood to return. So how is this useful? The doctor or nurse who would input all this information can see that the model's predicting that they have almost an 81% likelihood of being readmitted in less than 30 days. So that should really signal to them that they need to do everything they can to make sure that the patient has all the information that they need to try and take care of themselves once they're outside, or perhaps they need to be admitted to somewhere where they'd have more attention. And any sort of social workers that might need to visit them to help get them rehabilitated. Just really pull out all the stops for that patient to try and make sure that they're as healthy as possible so we can reduce that likelihood. So the second dashboard is helping us to compare the average patient. So we have on the left-hand side these various metrics, such as diagnoses, like count of diagnoses, lab procedures, medications, other procedures, hospital visits, length of stay in the hospital, and these are average counts per patient. So here I can toggle with these parameters to see what the readmission probability was. So right now I'm looking at for all patients. But I could also change this and say, well, what about people who have a 50% likelihood or greater to be readmitted? And so we'll see that this changed a little bit. We can also select a metric to split this information by. So perhaps we want to see, are there any differences between diabetes types, such as type 1 or type 2? So here, the bar chart split that by type 1, type 2, and type unspecified. And so there's a little bit of variation here, but not a ton. We could change also by age. And here, there's a decent bell curve here in count of medications. Looks like more emergency visits for younger people, more inpatient visits for younger people, as well as count of previous visits. So perhaps the young people in the data set are far sicker. I'll also do this by gender. Not a lot of variation there, but I think you get the idea of that. We can also filter down further to the different types of diagnoses classes. So if you knew that your patient was 80% likely to be readmitted, you might want to see kind of what are the average metrics that other patients that are 80% likely might incur. So did we have 46 lab procedures for this specific patient, or are they kind of above that average? So that's how this dashboard can be used. Finally, we have a patient dashboard. So we would just select or enter the patient ID that you would have from the patient chart. And this would just simply provide information from the current visit and previous visits that you're theoretically having with that patient. It would have information known at the time of admission, such as how it was referred, the race, gender, age, and what the payer type was. So here, this is a Medicare payer. So if they were to be readmitted, this is a patient that we would definitely be incurring a penalty on. They returned in less than 30 days. Here are the diagnoses that they had in the last 2 encounters. I can hover here to see what medications they're taking. The values here would be yes or no for each of those medications. And then based on each of their previous encounters, what was the probability of readmission for that? So it looks like perhaps this patient got a little bit healthier from the first visit to the second. They had an 86% probability the first time and then an 81% the next visit. So hopefully we were able to get them a little bit healthier, and hopefully that probability decreases from there. So that's an overview of the dashboards, and I will switch it back to the presentation to discuss a tool review of what we used for all this work.
Sure. So this is a high-level summary of our recommendations and findings surrounding the several analytics tools that were used and evaluated during our project work. SAS and R are 2 well-known statistical programming languages that are often compared to each other. Each are effective and offer a wide variety of statistical analysis and modeling functionality. SAS has been the undisputed market leader in the commercial analytics space for some time and was used to perform an exploratory data analysis on the diabetes dataset, as well as OLS and logistic regression analyses. SAS offers a huge array of statistical functions and, as compared to R, provides some advantages in terms of data handling capabilities, the ease of use surrounding the user interface, and the speed at which a user who is new to SAS can become proficient with the tool. However, SAS is the more expensive option and is not always enriched with the latest statistical functions. R is the open source counterpart of SAS, which of course is one of the most appealing aspects of the tool. Due to R's open source nature, users can submit their own packages and libraries, and as a result, the latest cutting-edge techniques are released in R first, giving it a clear advantage over SAS in terms of making new advancements available. R also offers advantages over SAS when it comes to data visualization, where there are numerous R packages providing advanced graphical capabilities. SAS offers base-level graphical capabilities that are more difficult to customize and less functional as a result. And while there will always be technical nuances that can be debated when comparing these tools, R can be thought of as the open source equivalent of SAS, and because R offers much of the same statistical capabilities, it is the recommended tool going forward. Angos is another analytics tool that our team has evaluated and recommends for use. Angos Knowledge Studio is an advanced modeling application that was primarily used in this project for data exploration and to build decision trees. And while Angos offers many advanced modeling features, including especially strong decision trees for segmentation and modeling, as well as many options for easily integrating with other analytical environments, its greatest strength is its ease of use. There are no programming skills required for building advanced models. Everything can be accomplished within the intuitive user interface. Also, Angos offers powerful automated workflow capabilities that guide users through the data preparation, exploration, modeling, and scoring processes, and also includes excellent visualizations which make every step of the data mining process easy to interpret and present. And this is in stark contrast to Weka, which is a machine learning suite, which we also used and evaluated. And although Weka is very powerful and provides a large selection of algorithms, it is more difficult to use and is especially challenging when it comes to interpreting and presenting results. And for these reasons, Weka is not recommended despite the fact that it is open source. And lastly, Tableau is the data visualization tool that was used to develop the dynamic interactive dashboards that were just presented. And as you have seen, Tableau is very intuitive from the end user perspective and offers the ability to dynamically interact with your data. And this allows users to consume information both at a high level while also providing the ability to drill further down into the details and immediately answer any new questions that may surface. And the same characteristics that make it easy to develop dashboards and interact with them also make Tableau a very effective tool for exploratory data analysis purposes. There are a wide variety of out-of-the-box visualizations available, which can be used to scrutinize your data and easily see frequencies and distributions, spot anomalies, and evaluate outliers. And following the development of predictive models, Tableau can be leveraged to effectively review and communicate model output, which makes it easier to convey important insights throughout the organization. And like Angos, Tableau is very easy to use. Again, no programming is required. For example, database joins that would otherwise require complex SQL scripts can be easily accomplished via Tableau's drag and drop capabilities. And this is important because Tableau's intuitive nature significantly lowers the technical bar required to effectively use this tool. And overall, Tableau is a powerful tool that makes it easy for anyone to better see and understand their data. And as a result, the team highly recommends that XYZ Health Systems continues to use Tableau for future projects.
Okay, so we've been talking for a while. And so let's talk about what's next for us. For this project specifically, we want to start testing it with the end users to get them on board, as well as make the necessary preparations for deployment and maintenance. Obviously, this is going to be an uphill climb. We don't want to be overruling what line doctors think, right? This is a model. This doesn't overrule their experience. We don't want them to think that we are telling them what to do. We're not doctors. We're data scientists. It's a different thing. What we want them to view this as is as one more tool in their arsenal that can help them to provide better patient care. It's not the be all and end all. Um, since this is our pilot, and we view this as sort of the first project in a long line of projects, getting buy-in at the ground level from doctors and hospital staff is going to be key for our long-term success. So we really need to do more to test out with them before we go live. Um, I'd also like for us to think a little more about overall direction at this point. So we've gone into the details about this particular project, and we believe that predictive analytics projects like this one really are the way forwards. As we've shown, big data has the power to dramatically improve hospital efficiency, give our patients better outcomes, and, very importantly, reduce our network's costs going forwards. We've really only begun to scratch the surface of the possibilities. There's enough to keep a stable of data scientists busy for decades. It's really an exciting new frontier that we're dealing with here. Just think of all the different things. You can predict how long a patient is going to be in the hospital very early on, so you can start managing staffing and treatment. Making sure you have enough nurses and working out their schedules to cover the 24-hour shifts. It takes up an enormous amount of administrator time right now. that could be fixed with the right optimization algorithm that takes into account things like nurse specialties, the number of patients, all of these things. Um, we've talked about diabetes in this particular one, but obviously we could take a very similar approach for things like heart disease, Alzheimer's, cancer, or really anything. Uh, for this as well, for diabetes alone, we've also only looked at a simple probability of readmission. But if we had better data, we could make a lot more detailed predictions. If we had, say, more granular day-by-day data, etc. Another thing to think about is that hospital mistakes cause a huge number of deaths every year. Doctors ordering the wrong prescriptions or nurses delivering the wrong dosage. I mean, they work hard, but sometimes people make mistakes. So imagine a system that could spot errors when they're entered by looking for incongruous prescriptions or procedures and then sound an alert. On the other side, think about all the billing errors or data entry errors. People who are diagnosed with the wrong disease completely by accident. Much like a lot of financial institutions now use things like fraud detection systems, the right algorithm could look for billings and diagnoses that just don't fit the usual pattern and flag them. I came up with these just, sitting in my chair for 5 minutes, and I'm sure we could come up with hundreds more if we were to do a more comprehensive study. So we really do need to take a step back and think about what are some of the long-term directions that we want to go with this. Next slide, please. So all of this is only going to be possible if we continue to collect high quality data. If we look towards the horizon, one of the big new buzzwords is something called the Internet of Things, right? It really just refers to a bunch of small single-purpose devices that are connected together. So in a hospital, this might mean that your O2 sats, blood pressure, EKG, your body temperature, skin tone ducts, all these different things are all being collected digitally second by second. A lot of machines are doing that right now. But the key difference is going to be that once these machines start talking to each other and we start being able to run real-time analyses on the data as it's coming in, uh, that's when things are going to change. The algorithms might be able to spot a problem long before any human can and sound an alarm or even intervene on its own. So imagine a patient in intensive care who their heartbeat is starting to get a little bit irregular and they're about to go and have a heart attack. The machine might be able to detect that even before a doctor could and intervene and stop it before it even gets started. Uh, so the IoT is going to change a lot of things going forward, and that really is something that we are going to need to be prepared for. So what we've talked about today and shown you today is really just the beginning of an exciting new era for hospitals globally. We need to be prepared to leverage this future as soon as we can and to be an innovator in the field. Thank you for your time. Does anyone else have anything else they want to add? Okay. We're very sorry that we weren't able to present this to you in person, but please do let us know if you have any questions or comments. And please play around with the dashboard and let us know what you think. Thank you.